So although this is quite a broad topic requiring its own separate lecture, I do want to spend just a couple minutes talking about AIDS-related pneumonias, as they're quite common in this setting. The most common pathogen identified in an HIV-related pneumonia are still typical bacterial pathogens, most commonly Streptococcus pneumonia, followed by Haemophilus influenza. Gram-negative bacilli and Staph aureus assume increasing importance as immunosuppression worsens, presumably due to both neutrophil dysfunction as well as selective pressure of other antimicrobials. Pseudomonas has been associated with neutropenia in patients with AIDS-related pneumonia, as well as with prior treatment with cephalosporin, and in those with a CD4 count less than 50. MRSA pneumonia in patients with AIDS can be quite severe and commonly leads to cavitation on chest X-ray. Pneumococcal vaccine is recommended for all HIV patients who have a CD4 count greater than 200 less than 200, and influenza vaccine is recommended for all patients with HIV regardless of CD4 count. The second most common cause of pneumonia in patients with HIV and CD4 count greater than 500 is tuberculosis. The clinical presentation of TB in HIV patient depends on immune status, as you all know. In early HIV disease, presentation tends to be typical pulmonary TB, but as immune system deteriorates, mycobacterial infection are more likely to be disseminated. Incidence of PCP infection rises dramatically when the CD4 count falls to less than 200, especially in patients who are not on Bactrim prophylaxis. PCP in patients with HIV infection usually presents subacutely with progressive dyspnea, non-productive cough, and fever. Tachypnea is the most common clinical sign that's observed, and the lungs are typically clear on auscultation. If pleuritic chest pain or acute worsening of symptoms is present, it is unusually to be a result of PCP infection, unless the patient has developed an acute complication such as pneumothorax. Diagnosis of PCP is usually obtained by induced sputum, the sensitivity of which is about 55%, or bronchoalveolar lavage, the sensitivity of which is 95%. Fungal pneumonias primarily occur in patients with advanced immunosuppression and a CD4 count less than 50. Histoplasmosis most commonly presents with disseminated disease with fever, weight loss, lymphadenopathy, diarrhea, as well as mucosal lesions, especially in the mouth. Histoplasma can produce also a sepsis-like syndrome with fever, hypotension, and multi-organ failure. The presence of hyaluromediastinal lymphadenopathy may help you distinguish histoplasma from PCP, as the clinical presentation in HIV patients is quite overlapping. In patients with pulmonary histoplasmosis, the chest X-ray is normal in 40 to 70% of cases. Viral pneumonias as well are not uncommon in patients with HIV, the most significant of these being CMV. Clinically significant HIV-related CMV infection is associated with severe immunosuppression. In other words, a CD4 count less than 50. Chest X-ray usually presents as bilateral disease, and CT findings show interstitial changes. Differentiation of PCP on the basis of radiographs of CMV from PCP based on X-ray alone is very difficult. And in most cases, even in patients with positive bronchoalveolar lavage cultures of CMV, an alternative diagnosis, most commonly PCP or bacterial pneumonia, is also identified. So be careful before you empirically diagnose CMV, and really diligently look for alternative infections if you suspect this. Parasitic infections that are significant in patients with HIV and AIDS include toxoplasmosis. It's most common parasitic infection, and it's seen in a patient with CD4 counts less than 100. The clinical presentation of pulmonary toxoplasmosis is again similar to that of PCP, But unlike PCP, it may be accompanied by a sepsis-like syndrome with hypotension. As with PCP, an elevated LDH is commonly reported on lab findings. Chest X-ray will often show you interstitial infiltrates, but also nodules, pleural effusion, or even a mass-like lesion. Diagnosis may be established by identifying toxotachyzoids on Giemsa stain of bronchial lavage or on tissue biopsy obtained through VATS or rarely a pleural biopsy.